system assessment. This is basically still in relation to health assessment. So this morning we had the nervous system, and right now we are going to handle the musculoskeletal system. So I want us to start by getting to understand the assessment techniques in relation to musculoskeletal system assessment. So the first thing you have to do is to gather the patient's history, and by you doing this, you have to know whether the patient had a recent trauma. You need to know about the patient's past surgeries that the patient had, then also mobility issues. So you need to know whether your patient has ever gotten any kind of issues in relation to his abilities to move, to walk, and so forth. So changes also in the gait of the patient, you need to understand that by asking the patient whether he has been walking in such a kind of posture or it has changed. And also the musculoskeletal diagnosis, find out if your patient has ever had any kind of musculoskeletal conditions, and then you'll be able to understand any issue in relation to the musculoskeletal system of your patient. And the other thing, you need to also know about the medications affecting gait. So you need to know what kind of drugs your patient is taking and what drugs can affect the gait of an individual. And the second point is basically the chief complaints or symptoms. You need to know what could be the complaints of your patients and what could be the symptoms that can be relating to the musculoskeletal system related conditions. So inquire about pain. If your patient has pain, where is the pain? Then in case of any swellings, find out what are the swellings about, then stiffness of either the limbs or the neck and so forth, and any kind of inflammation. Also inflammation is also related to the musculoskeletal system, so you need to find out. Then assess the duration. When did it start? How long has it taken? The onset is actually when it started, then the duration is how long it has taken, and the severity of the condition, either the inflammation, the swelling, or the pain. And also you need to know the impact on daily activities. Is the patient able to carry out his daily activities? And if he's not able, then what could be the reason? So those are the things you need to find out from your patient. And these questions should be tailored for the case of the neck, the joints, and then also the back pain. The third point is basically to perform inspection. And I remember when you talked about the assessment techniques, we managed to understand that inspection is actually one of the first techniques that we all have to do when we are carrying out assessment on our patients. So you have to evaluate the joint symmetry. Is the joint actually in the normal size, the normal shape, or one side is swollen, one side is maybe depressed, and so forth. Then the deformities, you also need to assess for any deformities in relation to the musculoskeletal system, and muscle atrophy. And muscle atrophy is like reduction of the size of any kind of muscles in the different areas of your patient's body. Then check for inability or for maybe moving, which is immobility. The patient cannot move, the patient cannot walk. The swellings, redness, which may be the sign of inflammation, and then the skin abnormalities can also help to indicate something. Then also observe for the posture of your patient. Sometimes when they sit in a certain posture, it may help you to know that maybe this patient is feeling pain on this other side, either the lower limb or either the joint, and so forth. Then the head and the neck position also you can tell. You may find the patient has tilted the neck on only one side. You tell him to turn this side, he cannot, and that can be a sign of any problem in relation to the musculoskeletal system. The gait of the patient, the weight bearing. Somebody can be very heavy, but you realize that the lower limbs are not able to hold the upper weight. So you also have to discuss about this. And then the leg swellings, swinging of the legs. Is the patient able to swing the leg or he's not able? The knee movement, also you need to see that. And then the foot positioning. So all this can help you get to understand what your patient is actually suffering from. Then also perform palpation. Palpation, you have to palpate by touching and feeling. So you assess the skin and the muscle temperatures. You can find maybe if there is inflammation, that part can be maybe feeling hot. You can touch and you find that this place is having a lot of heat inside, which can be a sign of inflammation. And there can be tenderness. As you touch, the patient may reflect pain inside. Then the swelling or the masses, you may also palpate and you realize that there are masses that could be in the muscles of your patient. And then compare the affected and the unaffected area. If you see that the patient is complaining of the limp on the left hand side, then maybe you have to look at the right hand side. How is it? Maybe in relation to the ankle joint, what is the problem? Is this one more bigger than the other? Are they asymmetrical, that one is much more smaller, this one is swollen, and so forth? So those comparisons can help you understand which limb or which area of the limb is actually having a problem. Then also palpate the bony landmarks, the synovial joints for pain and the swellings. And this one can be in patients mostly who have arthritis. They always have those painful joints due to the maybe reduction of the synovial fluids in relation to these joints, which helps the joints to move. So when they lack that, they end up having those joint pains. So you can also assess that as you continue palpating in different joints. The patient will express to you how he's feeling. And especially when a patient has arthritis, there can also be swelling due to inflammation in those different areas of the joints. You also have to assess the range of motion. Range of motion is like a movement. So in case it is on the shoulder, what are you going to look at? You look at the flexion. Arms can be forward to 90 degrees and over the head to 180 degrees. So you tell the patient to put the hands over his head and see whether he's able to do that as you're observing his shoulder. Then extension, the arms can be backward to about 80 degrees. Tell him to try to put his hands behind if he's able. If he's not able, then he may express some pain, and that can be around the shoulder region. Then adduction, arm across the front of the body to 90 degrees. So you tell them to do this. As they do that, you observe the shoulder, and that can be giving you a sign of either shoulder joint pain in case there is anything that has happened and it has affected the joint around the shoulder region. Then adduction, these are arms. You make the arm out to the side to 90 degrees and over the head to 180 degrees. Then internal rotation, arms behind the head, bend at the elbow and attempt to touch the opposite shoulder blade. So you tell the patient, can you try to touch this other side of your shoulder and see if he's able to do that. Then for the external rotation, the arm is raised, bend the shoulder, and then you also clasp. You can tell the patient to clasp the hands behind the head. Put his hand behind the head if he's able to touch his head on the back. Then you can be able to assess the movement of the patient's shoulder, and these rotations can help us to know where the patient is feeling pain, because the indications of this pain in these different flexions, either on extension, adduction, abduction, external rotation, internal rotation, can give you a sign of a particular either nerve that has been affected. And if there is anything like maybe a dislocation or a fracture, you can also be able to tell. So when you look at the elbow, we understand that the elbow is basically one of the joints in our hands. So when you look at the extension, you tell the patient just to straighten the elbow. Tell the patient, if you're seated, can you make your hands straight? Then you watch on the elbow whether it is stretching completely or not, or he's feeling pain. Then flexion is just basically bending on the elbow, trying to fold the hand, and then you'll be able to assess, is he able to fold it or he's feeling pain on folding? That is flexion. Then you can be able to tell. Then supination is to extend the arms forward and then you turn your palms up. So you just stretch your hand, but your palms should be up so that you can see the arms the part of the arms upward, both of the hands. You can do that, and you compare where your patient is having either difficulty in supination or the patient is able to supinate all the both hands. Then pronation is just stretching the hands forward, and then you turn the palms down. So you only make sure that the hands are straight, but the difference between supination and the pronation is just that when you're doing the supination, the palms are turned upward, and when you're doing the pronation, the palms are turned downward, so you only see the back of your hands, or the palms, I mean the back of your hands here. Then the palms is when you see, and the person is doing the supination kind of rotation or motion. The other thing is assessing the range of motion with the wrist, the fingers, and the thumb. So here you're going to tell the patient to do some extension whereby the arm is in front, the palm is turned down, and the fingers point upward. So these extensions can be done when the patient has maybe told you how he's feeling, maybe the hands he's feeling pain. So you're trying to identify, is it at the elbow, is it at the shoulder, is it at the wrist? So you tell them to do all this range of motions, and when they're doing it, they're able to actually express either pain or difficulty in doing the different range of motions that you're telling them, and there you can be able to tell where the problem is, whether it is radiating or it is localized, or the pain is making the patient not to move the hands, which is immobility, and so forth. So all this you can be able to know where the problem is. Is it at the wrist? And if it is at the wrist, does it radiate to the fingers, to the thumb, or it is basically only the thumb and it is radiating maybe somewhere else? Depending on the cause of the pain, to these patients are different areas or different sites of his hands. So for this case, in case of the fingers, you can tell the patient to do some flexion, and on doing the flexion basically is to make a fist. Then after making a fist, you can tell them to do an extension, which is basically straightening or opening the hands. After making a fist, tell them to open, release their fingers slowly as they explain to you, whether they are feeling numbness or they are feeling pain and difficulty in opening the hands and stretching the fingers. Then extend the hand and spread fingers apart. They just open the hand and they spread their fingers open. And then adduction is to bring fingers back together. So all this can be done in relation to assessment on the range of motion to the fingers of your patient, and then you can be able to tell this finger cannot stretch, this finger cannot actually extend, this finger when it tries to flex it cannot make a complete fist because either the thumb is having a problem, or the index finger, or the middle finger, just like that, and you'll be able to get to know which part of the fingers are actually having a problem and why is the patient complaining. So when you look at the thumb you can do the same things. You do the flexion whereby you move the thumb across the palm. You fold the thumb. You just fold it across the palm and you see whether it is able to fold across the palm or it's not. Then also extension is just to move it away from your hand or from your palm. Then adduction or abduction, you move the thumb away and back to the hand, just trying to stretch it backward if it can stretch after removing it from your palm. That is the one that is adduction or abduction. So you have to try to do this several times as you're observing the patient. You just give him the command or demonstrate and tell them to repeat after you. Then also opposition, touch the thumb to each finger. Is your thumb able to touch each finger? And I believe some of us might have tried this, or else you can try to do it. Make your thumb to touch the index finger, make your thumb to touch the middle finger and the small or the little finger, and it can be able to touch each of them. But if your thumb cannot touch each of these other 4 fingers, then there is a problem either in the joint of your thumb or it is in relation to the nerves and so forth. So additional assessments for the wrist, fingers and the thumb. So you have to try also to hand grip test your patient by assessing the hand strength, by having the patient squeeze your fingers. Just give the patient your fingers and tell him, can you hold me? Then he can hold you and is able to squeeze, and you'll be able to feel how what kind of strength he's actually trying to put into when he's squeezing your fingers, or he's finding difficulty in even squeezing your fingers. Then Fleckley-Stein's test, that one also have to assess the thumb movement and function. Basically you have to look at the previous slide. Is your thumb able to move, and is it functioning by touching these others, and so forth. Then the Tinel sign is to tap over the area to test for nerve irritation. So you just try to tap the fingers of your patient or the wrist or the thumb and see whether there is any kind of response in relation to the nerve kind of irritation, and there you can be able to assess whether the nerves are working or these nerves are affected. Then the Fallen's test is to assess for median nerve compression. The median nerve compression can affect all these fingers. If there is a problem with the median nerve, then there will be loss of function in these fingers, because it is able to actually supply, or it is the one that is responsible for all the activities, the movements and so forth of these wrist, fingers and the thumb. So when the median nerve is affected due to either compression from the other neighboring bones and so on, then you can get a problem with your wrist, fingers and the thumb. So you also have to assess the range of motion in relation to the cervical spine, and most of our clients who have gotten this cervical spine injuries have always ended up with a lot of complications. So you can tell the patient to flex. So in the case of flexion, you tell the patient to bend the head forward, touch chin to chest, make the patient to make his chin touch his chest, and then you're able to see whether your patient's cervical spine is actually functioning well, or there is difficulty, then there is a problem. Then extension, to look at the ceiling. Tell the patient to look upward at the roof, and if he's able to do that, then the cervical spine is okay. But if he's not able to do that, then you may get to know that this patient has a challenge with his cervical spine, and may need more assessment to find out where the problem is. Then rotation, look over each shoulder. Tell the patient to look at his shoulder on the right hand side and tell him to turn even on his left hand side, and see if he's able to rotate his cervical spine, so that he can be able to see all both sides equally. Then lateral bending, bring ear to each shoulder. Let the patient try to turn his head on the left hand side until the ear on the left hand side touches the shoulder on his left hand side, and let him do the same on the right hand side. Make sure that the ear on the right hand side is turned up to the shoulder to touch the right hand shoulder. Then you can know that this patient's range of motion in relation to the cervical spine is good. The spinal column can also be assessed by bending forward and touch your toes. Tell the patient, can you touch your toes, and see if he's able to bend and touch his toes. Then extension, bend backward from a standing position. Tell the patient to stand and tell him to try to bend backward and see if he is able. But don't do this so much on a patient, and if he has resistance to bend backward, don't force the patient, because you may cause harm to the spinal cord of your patient. And then the rotation, turn side to side without moving their feet. Tell the patient to stand with his feet straight on the ground, and tell him to turn on one side, then also turn on one side, but never to move his feet. And then lateral bending, bend from side to side at the waist. Then you tell the patient to stand straight and tell him, can you bend on one side? Sometimes you can tell them, touch your feet on one side, or either on the left hand leg and bend that side, then also on the other side. That is now when you're assessing the spinal column. For the case of the hip, you may do the same kind of rotation, the range of motions, you have to do the flexion, and that is spine position, raising the leg with the knee extended, and then extension prone position, lift the leg posteriorly, adduction and abduction, you move the leg away and towards the midline. So you have to try to do all this as you're assessing the patient to see whether his hips are actually not having a problem, because there are people, you tell them to do this, they cannot do it. Why? They might be having problems with their hips, or the person was replaced, maybe they put something like a metal when you got a problem with the hip joints and so on. The internal and external rotation, bend the knee, move the foot towards or away from the midline. Midline is just if you're standing straight and your legs are together, you are at a midline. But when you are standing and you move your leg away from the position where it was as you're standing straight with the legs together, then you are moving the legs away from the midline. That is basically what this statement means. And also now you need to assess the knee itself. So flexion, bend the knee or squat. Tell the patient to try to bend. If he's able to bend his knee or squat, then that is good. Extension, straighten the knee from a bent position. If you're bent, can you be able to make your knee straight? Then external and then internal rotation. This is maybe sitting in position. You put the patient in a sitting position, tell him maybe to swing the lower leg towards or away from the midline, and you'll be observing whether this patient is easily doing what you're telling him to do in all this range of motions. So we want to look at the ankle and the foot. You also need to look at this and see whether they have good range of motion. The plantar flexion, you tell the patient to point the toes. Point the toes is just for him to make his toes straight and is able to point them out from his foot. And then the dorsiflexion, you raise the toes towards the ceiling. Tell him to raise his toes up and see. Sometimes we should be trying these things. You just sit, and as you're sitting, you just try to lift your toes, just the leg doing it, not by your hands, and you'll be able to know whether your toes are functioning normally or not. So some of these things, it doesn't mean that you should only be assessing when you are sick, but you can also be doing this just like an exercise at home. So inversion is to bend the heel inward, whereby you just put your legs, the foot, you put it straight on the ground, then you try to bend your heel inside, then also bend the heel outward, just opening it out as you lift the heels. So these exercises are not only for the patient who has come to the hospital for assessment, but you can do this also for yourself and assess yourself whether your joints are actually in a normal range of motion or you have a difficulty. Sometimes we live with these inabilities when we don't know. Just because we don't try to do it out, we wait to do it to our patient, but we don't do it to ourselves as health workers. And then the muscle strength scale is at 4. So if there is no contraction as your patient, then it is 0. Then trace muscle contraction such as a twitch. If there is just a twitch, then you give 1. Active movement only when the gravity eliminated. So you have to do this to all your patients in different areas of the muscles. You don't do on one side. If it is lifting the limb, try to ask him on both sides. If it is the leg on the right, then also try on the leg on the left. If it is the hands, try on both sides, and you'll be able to know what is happening on both sides of the patient's limbs, both the upper and the lower limbs. Ask movement against gravity, but not against resistance. Then there you also try to tell the patient, can you lift your leg? The patient can try to lift, and then you observe as he's lifting, and also tell him, can you lower it down? Then you observe when he's lowering it down. Does it go just in a very fast way, or it goes slowly, gently until it reaches back to the ground. Then also active movement against gravity and some resistance. This is now whereby you tell the patient either to lift his hand and you put pressure on the hand and see if he's able to resist the pressure. And maybe the leg, you tell him to lift the leg, then you try to hold his leg, not actually holding it in between your hands, but you try to put pressure on the legs and you see whether he is able to resist the gravity that you're trying to insert on his legs, and is he able to move those legs down slowly until they reach down, or when you put a resistance on them they just fall down immediately. So there you'll be able to assess your patient's muscle strength. For the strength, the upper extremity strength assessment, there's bilateral hand grip strength. Tell the patient to try to hold something in his hands for some time and see if he's able to put that pressure and hold the thing that you're telling him to do, and do it on both sides of his hands. Don't only use one side and you say he has a very good muscle strength, but try to do it on both sides of the hands. Then also resistance during arm extension and flexion. Try to also look at that. If you're telling the patient to stretch his hand and you're putting some resistance, is he able to do it beyond the resistance, or he just fails to do it? Then the lower extremity strength assessment, resistance during leg lifting, leg pulling, foot lifting and foot pressing. And I mentioned that as I was explaining in the previous slide. I talked about exerting pressure on either the upper limb or the lower limb, looking at either the legs when he's trying to lift, then you put their pressure and you see if he's able to resist it, or the legs just go down back very fast. And then expected versus unexpected findings. And when you look at the book for health assessment, you'll find out that there are these tables that are being referred to. So on inspection, there should be an erect posture and symmetrical joints. The joints should be the same. They should not be, if it is the ankle joint of the right hand side, you should also see that is the same with that one on the left hand side. In case they are not, what could be the reason? Then on auscultation, you can auscultate and you say crepitus associated with pain. So when you listen to any kind of pain and it's showing some crepitations, then you just know that this is an expression of pain along that joint. And then on palpation, you palpate and maybe there is no tenderness, then you just know your patient is not having pain, because there are patients who can come to you and they will tell you, I have pain on this joint, but when you palpate you don't see any expression of tenderness, you don't see any expression of showing either there is pain. Then you just know the patient might have been having maybe some kind of just a thought or some kind of attention seeking. But in most cases, we need to first find out, we need to assess, we need to do the palpation, and that's when we shall be able to know that really there is no tenderness here, these muscles are okay, and the patient is fine. So the score for this is basically supposed to be 5 out of 5 as a total for muscle strength. So when you're assessing for this muscle strength of your patient, you're able to you are supposed to score it out of 5. So we should be knowing how to score this so that you can be able to tell the muscle strength of our patients in relation to the different areas that we always carry out assessment in. For that case, I think this is what we had to cover up today. And in relation to the musculoskeletal system, so we are supposed to assess the different regions, the different parts of our patients' bodies. You first have to start with looking at the patient's abilities to move, and if the patient is not able to move, what could be the problem. And basically the musculoskeletal system is not only looking at the bones, but we are looking at the muscles, we are looking at the different cartilages, we are looking at the different joints. So we need to understand what the musculoskeletal system comprises of. And basically it also looks at the general anatomy of the musculoskeletal system and looks at the functions of those different musculoskeletal areas or system. And we need to know how they function, we need to know how they look like when they are actually having any kind of deformity or any kind of infection, so that we can be able to differentiate the normal from abnormal. And I've always tried to say this several times, that we need to know the normals, so that when we are examining our patients, we are able to tell this is abnormal and this one is normal. Then we can be able to handle them appropriately. Then also we need to assess our patients' performance of their daily activities. You know, it's very important for the patient to perform his daily activities. If he's not able to perform his daily activities, then the patient may not be able to support himself. So we need to look at this critically in order to help these patients be able to support themselves in relation to musculoskeletal system. The assessment techniques, we talked about this, and we said we need to gather information and basically looking at the history. And then basically we also need to know the chief complaints and the symptoms that these patients present to when they come to us. And on inspection, you have to assess, you have to observe, and when you're observing, you're able to identify any abnormalities that the patient is presenting with in relation to the musculoskeletal system. When you palpate, you're able to also identify some of the signs and symptoms that the patient may present to you with in relation to the musculoskeletal system. And as you're palpating, be sure of what you are looking for. So in relation to the range of motions, we have talked about different areas that are supposed to be assessed. We talked about the shoulders and explained how we assess the shoulders. We talked about the elbow, and also we tried to explain how do we assess the range of motion in relation to the shoulder and the elbow. So this is basically how the client is able to move the shoulder, how the client is able to move the elbow in different angles, and how is he feeling as he's doing that, and is he able to do that, or is finding challenges in doing so. And not only the shoulder and the elbow, we are looking at even the wrist, the fingers and the thumbs. So when you look at that, you're able to get to know where the problem of your patient lies, and you'll be able to also help them manage in relation to the issues they have come to for you to help them. Basically, that is what we can take up today in relation to the musculoskeletal system. And if there is no any other question, I just encourage us to read more, and we shall have the best knowledge on musculoskeletal system assessment, because most clients come but we fail to assess, and they go back with challenges in their mobilities, which is a big that this is the end of our session for now. Thank you.